Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University and the Alan B. Levan Innovation Center, which is a combined effort between Broward County and Nova Southeastern University. And today we have some really spectacular people that are very close to the university, to NSU. They both graduates of the NSU College of Osteopathic Medicine. And we're going to talk about advanced spinal surgery. Let me introduce first Dr. Yoav Ritter, DO, a neurologic specialist at HCA Florida University Hospital, which is right out the window here, I can see. And then, of course, we have Dr. Stephen Vanni, who is a return person to the show, and he's also a neurological specialist. So welcome, both of you. Welcome.
Thank you.
Let's start with you, Dr. Vanni. Tell us what a neurologic specialist does.
Well, we're a specialty of neurosurgery. So, a neurologist would be a doctor who diagnoses neurological problems, like a cardiologist would diagnose heart problems. And then once they see something that's of a surgical nature, they would refer them to a cardiac surgeon. Kind of the same thing. We're the guys that if you need some type of aggressive intervention or even non-aggressive, but something surgical, we're the specialists for that. So whether it's operating on the brain, a nerve in the body, or the spine or the spinal cord, we're the physicians that take care of this. And both Dr. Ritter and myself were partners here at the University Hospital and have been working together for some time.
What are the most often presented to you cervical and spinal disease injuries?
Great question. The most frequent thing that someone walks in our office complaining of is either neck or back pain. The question is, what's the cause? Is it a disc herniation, which is probably the most common surgery we do, both myself and Dr. Ritter. And then there are a whole host of other injuries they can suffer from, but especially in our community here, as we age, a very common problem is spinal stenosis, where patients' spinal canal becomes narrowed. There are various treatments that we can utilize for that. They have complaints of pain in their legs when they walk, very common complaint. Some patients come to us with complaints of deformity. Both myself and Dr. Ritter are deformity experts. There are complaints of pain down the arm or pain in the leg. That's usually from a disc herniation. And there are different procedures that we can utilize for those disc herniations, whether it's doing a fusion procedure. And I brought some models to show you if we get to that point, where we can place a spacer between the vertebra and screws, or nowadays, there are actually artificial discs that we can place inside of the patient to mimic as if you would an artificial knee or an artificial hip to put the normal motion back in that patient. And again, some patients have these deformities, especially where we have to put in rods and screws to correct their deformities.
We do have questions. People say, well, gee, people are saying I'm all hunched over or I'm not walking up straight. Tell me about that.
So as we age, I brought a model of the spine. This is what we call a sawbones, or just a plastic model, but the ligaments that connect these vertebrae together to allow them to stay flexible, like everything else as we age, they degenerate. The disc spaces collapse, there's cushions between the vertebra, the ligaments start to enfold upon themselves, and so the opening in the spinal canal becomes very narrowed. And that narrowing is known as spinal stenosis. And patients may be familiar, like in a heart condition, when the vessel's narrowed and they put a strain on their heart, they get chest pain. Well, when the spinal canal narrows and they're trying to walk, they're putting a strain on the nerves, and that strain will result in leg pain or heavy sensation. They have to sit down. And a lot of times you see the patients are bent forward, and they're holding onto a shopping cart. They can walk a longer distance. And that's because when they're bending forward, they're putting those nerves on stretch and they're opening their canal a little bit, and they can walk a little bit further. So myself and Dr. Ritter, we treat a lot of these. We do them a little bit differently. I'll let Dr. Ritter speak. He can actually decompress an entire spinal canal through a little tube. Believe it or not, patient can go home with a small hole or an incision in their back less than an inch long and decompress a spinal canal. When we do those tubular decompressions through a metrics tube.
Dr. Ritter?
Yeah, so when you try to decompress a spinal canal, because the goal is to allow the nerves to breathe when there's significant compression, you could put a very small tube and you can angle up or down, side to side, really utilizing a minimally invasive technique where the damage that you do, or the dissection that you do, I would say, to the tissues is minimal, yet you get the biggest bang for the buck as far as a decompression of the nerves. And by utilizing this metrics tube system, you could really get to numerous locations in the spine through a 18 millimeter, less than 2 centimeter incision.
And these patients usually go home in a day or the same day. These are
They go
done
home
as
the same
outpatient
day.
procedures.
Yeah, all things going well, they go home the same day.
Yeah, the reason I'll tell you, I think I mentioned this before, but I'll mention it again. We have, of the three topics that are the most queried by our longstanding group of individuals who are come to visit our show and listen to what we have to say, it's cancer, cardiac disease, minimally invasive techniques. And the reason is well, it used to be surgery, but now they talk about minimally invasive techniques because there's so much available to people that prevents the problems in their mind of being cut open and bleeding and sitting in hospitals for a week, 2 weeks, or whatever. So minimally invasive techniques are something of great interest to the viewers of this program. So I'm glad you brought it up. Go ahead.
No, I mean, the future of medicine is to, rule number one by any physician is do no harm. But when we're operating on a population that's aging, patients that are aging these days, it's different than years ago. These patients of ours, they want to get back to playing golf. They want to get back on the pickleboard court, tennis court. They want to get back to their activities that they enjoy. And the techniques that we employ allow them to do that much, much quicker than in years gone by, where patients, spine surgery, years ago was a very scary thought. You'd be laid up in the hospital, you're wearing a body cast or whatever their notion is. But there's a lot of techniques that we can employ today. One of the other things that I brought along in terms of toys is this little clamp that we can place. Usually instead of doing fusions, we're putting rods and screws in patients' spine like this. And even these rods and screws, where we do have to sometimes use these things or fixating the patient, we have different technologies that can allow us, number one, to not do a fusion, where we can preserve motion, where we can decompress the spinal canal and put a flexible clamp. And again, these are done as outpatients. Patients can walk around the next day. To even when we're putting in screws and rods in some of our patients, that it's necessary. And Dr. Ritter is actually an expert where we use this navigation system. He actually trained me to use it, where we could put these rods and screws with this computer-guided robotic type of system through these little half-inch incisions and fuse the patients back together.
Dr. Ritter, you want to add to that?
I think Dr. Vanni said it very well. We try to use the most advanced techniques to benefit patients. We try to make the incisions as small as possible because we know that what you do to the tissues matter. And because of that, we really try to tailor the approach to what the patient is asking and what the patient's problem is. And we really try to make sure that when we operate on something, we're very goal oriented to try to fix the problem that you came with and try to get you back on your feet as quickly as possible, as compared to doing large operations where you could be tied up and laid in bed for weeks. We try to really utilize the latest and most not minimally invasive, I should say, techniques.
Let me ask both of you, do you, do I presume, or maybe I shouldn't presume, but I'm going to ask you the question, do you refer individuals to physical therapy or other individuals that do things for you or aid you in making the people more viable?
So I think both of us have a very similar mentality when it comes to taking care of patients. We first, you mentioned, family, and we try to treat them just like we would treat our own family members. If it's a surgical technique approach or other modalities of treatment. And we always consider ourselves the last resort. So it's very common for Dr. Vanni and myself to see patients and to try multiple other treatment modalities that are non-surgical to see if we could avoid the surgical aspect of the treatment. If you fail the conservative treatment, and it could be very aggressive conservative treatment, anything from acupuncture, chiropractor, physical therapy, and pain management injections, if you went through that algorithm and you're still in pain that hinders your quality of life, then we talk to you about an operation. But it's very rare for us to say, hey, this is the first time that you're meeting us and you've not had any conservative treatment. Usually we would refer you in general to some type of non-surgical modality first.
Well, the reason I bring it up is because being an individual that has had spinal surgery before you guys, before both of you have, shall I say, received your educational opportunities, we have a sports medicine clinic, which is really a combined element of osteopathic, this College of Osteopathic Medicine and physical therapy. So they work with many of our folks here as well as athletic teams. So I'm just, that was my question.
Both of us are osteopaths, even though we're surgeons. We're both osteopaths. We both believe in a holistic approach. I was a chiropractor before I even went back to medical school. So we utilize a lot of different physical therapy types of treatments in our practice. We may not personally do them, but quite frequently, Dr. Ritter and myself were measuring patients, we're prescribing orthotics, heel lifts to balance out the pelvis. We know what chiropractic or osteopathic techniques work best for this particular patient. And so we're able to fine tune the physical therapy modalities. And we utilize Nova's rehab centers. Dr. Ritter's himself an athlete as well as myself, and did his testing there to optimize his physical health. So we're firm believers in that. And it's definitely a team approach that we try to utilize, utilizing the best type of physical therapy available for patients.
Well, the only reason I bring it up is because I don't know what part of the MOB medical office building that you're in, but if you look to the east, about less than 1,000 feet away from you is the sports medicine clinic, and that we have some wonderful individuals that are colleagues.
Both Dr. Vanni and myself are actually working in collaboration with that sports medicine treatment team to publish a paper, and they're doing some research that is hopefully kind of continue to progress with that team. Some of the PhDs there.
What is kyphoplasty?
When patients get a fracture in their vertebra, especially from osteoporosis, and what is osteoporosis? As we get older, the bone gets soft, and a patient can get a fracture. And anytime you fix something or repair it, or they call it a plasty. So when a patient gets this fracture and they go forward, they call that a kyphosis. So one of the techniques of fixing these fractured vertebra was, and that particular technique is more of a, should I say, patent or copyrighted technique, kyphoplasty. But there's other things such as vertebroplasties, vertilifts, that all trying to accomplish the same thing, which is stabilize that fractured vertebra. And a kyphoplasty in particular is a type of modality that we do through a little stab wound. I'll let Dr. Ritter elaborate about that because he does quite a few of these himself. Yoav, why don't you talk about the actual kyphoplasty procedure itself?
Sure. So the modality that we use like with the kyphoplasty is for somebody who has a fracture. Most commonly, these are fractures that occur in elderly who have osteoporosis. And both of us, Dr. Vanni and myself, talk to people about this fracture from two prongs. The first prong is treating the pain, and you could treat the pain sometimes with the brace, but if it doesn't help, you could treat them with the kyphoplasty. A kyphoplasty procedure is a procedure where through literally a stab incision, size of a pen, you could direct a needle into the vertebral body. Through that needle, you could deploy a balloon to open up the space in the bone, with the concept being to increase the height of the collapsed bone, and subsequent to this, deploying cement to stabilize that vertebral body that has been fractured. That's the treatment for the fracture. But more importantly, and both of us are very strong believers in kind of a holistic approach, is that you also have to make sure that there's subsequent follow-up in order to prevent further fractures. A fracture that most commonly utilizes the kyphoplasty or vertebroplasty modality, by definition, is a pathologic fracture. A pathologic fracture is a fracture that occurs when the forces that usually are the forces that the spine is usually subjected to is too great, and you have a fracture occurring. So it's not from a trauma, but it's just from everyday activity. The force of the spine is too great for that specific vertebral body, and it fractures. Those patients should be directed towards primary care doctors, endocrinologists, rheumatologists, in order to make sure that their bone density and the quality of their bone is taken care of. Because if you usually have a fracture like this, by definition, it's a pathologic fracture and you have osteoporosis. And if you don't take care of that, you're going to fracture the level above, the level below, and that's something that can be extremely detrimental to your health and longevity.
Yeah, we see this frequently. After their first fracture, they'll have multiple fractures.
Talking about that, there's so much that we get from, again, this is from people who are viewers. There is this fatal fall issue. People slip, fall, step over a molding or whatever, crack a hip, cause harm to a leg, all the way up to the skull. Are both of you, I would assume that you have a whole department which deals with the operative and caring procedures for events such as that, correct?
Right. Well, we don't do hips and knees. We do spines and brains. And one of the things that you frequently see, and I say my population, because I'm part of the group now, is that patients can get a small bleed in their head called a subdural hematoma, where they fall and the vessels break in the head, and there's blood between the skull and the brain, and it's squishing the brain. And those patients can present with just a headache. Some people, we just saw one in the hospital yesterday, can present with anywhere from a slight headache to being in a comatose state, depending on the amount of blood and the amount of pressure on the brain. And we have some different techniques that we can employ to treat it, whether it's drilling a small hole in the head to let the fluid out, to making a small area in the brain where we let off the blood pressure, the pressure in the brain. And again, I'll let Dr. Ritter talk about it. We sometimes will send patients to actually an interventional radiologist. What is that technique, Dr. Ritter?
Middle meningeal embolization.
And what do they do?
So basically, you go in through the vessels, and you go through the vessels in either the groin or the arm, and you could deploy this substance basically that takes away the blood supply to some of the coverings over the brain that supplies the blood to those supplies the blood that can cause the bleeding. And by devoiding and embolizing that specific vessel, a lot of the times that blood can get reabsorbed by the body, and you don't need any intervention.
Yeah, no surgery at all. As Dr. Ritter was saying, they can actually, the artery that supplies the blood to the covering of the brain, we can embolize it and take care of the blood that's accumulated in the head without any type of surgical intervention.
I think also to add to one of your points, as you mentioned, it's kind of like a sentinel fall. And, we've known that there is, at the time at least, there's a 50% mortality with the hip fracture. And it comes from the fact that, one, maybe it's the recovery, but two, why was the fall occurred? And both of us are very in tune with these things. And going back to the kyphoplasty and the fragility they're called fragility fractures, pathologic fractures. Both of us are very in tune to, okay, so you've had the fracture and we could fix that, but why did that fracture happen? And the fracture itself is not going to give you, that's not going to be a problem with your life expectancy. But if you don't treat that, and if you don't really take care of the underlying cause for the fracture, that's when kind of a spiral can occur. And both of us are very, I think, holistic when it comes to taking care of our patients, that we will refer you, guide you to where the next step, even though we are not the individuals that are going to be taking care of the osteoporosis itself, but we're going to guide you to where the next step needs to be and how to seek the needed medical care.
Well, the reason I'm glad you got to that, because certainly, and we've had colleagues of yours over the years that always say that it doesn't stop at my treatment. We have to advise people as to proper intake of fluids, proper nutrition, exercise, things of that nature, correct?
I mean, but absolutely. And I think both of us are, very, very health conscious. We will have discussions about things that are not neurosurgical, that are more exercise related, but you're absolutely right. And if you fall, when people talk about falls, well, if you don't have the strength to get up by yourself, and nobody's around and you don't have a cell phone, you could end up with a minor fall that should really have been a non-entity. But if you're there for 2 or 3 days because you physically don't have the strength to get up, that becomes a life-threatening event. Something that for a 30, 40, 50, 60-year-old, you just get up and brush it off. But for an 80-year-old or a 90-year-old that can't get up and nobody's around, that's life-threatening. Not because the fall was life-threatening, because the subsequent events that occurred are life-threatening. So both of us are very conscientious when we talk to people about, general health. And that's something that we really have a big passion about.
Well, we're down to the last couple of minutes of the show, so I'm just going to tell you that I'm very proud of the fact that I've had an opportunity to be part of your lives, both of you. We're proud of you. We know that you're both over at HCA University Hospital, which is, if I had my window not covered by a board here, I'd be able to see you and wave at you. So I'm waving at you now. We're both proud of. Yeah, we're both proud of you, and thank you for showing up today, because these questions don't come from me. They come from the people who are maybe going to be patients or some of your colleagues' patients, but they want your knowledge, they want your understanding, they want your caring, and as our founder always said, medicine isn't just taking pills and using a knife. It's always the opportunity to know that the person that you care for is another human being just like yourself. So thank you both for your time, your effort, your quality presentation as medical professionals. And remember that we're always here for you.
Thank you.
No, we greatly appreciate it. And Dr. Ritter and myself, I don't want to speak for Dr. Ritter, but he knows we treat everybody as a family, and we're proud to be part of this family as we watch this campus grow every day. I'm looking out my window now. I can't be more proud. We've started our research program here where we do cancer research, and all of your viewers should know that if they have any health issues, any questions, we're always a phone call away.
Okay, with that in mind, we're going to, with your permission, we'll put up a HCA University Hospital number, and if they want to talk with you, that's the way they're going to get to you. Okay.
Absolutely. Thank you so much.
Thank you both. Thank you both, Dr. Vanni and Dr. Ritter. Thank you kindly for being here today. Remember, this show is called Dateline Health. We come to you from Nova Southeastern University. Until next time, this is Fred Lipman saying, see you.